everyone. My name is Joe Morita, and I'm the Executive Acquisitions Editor at Springer Publishing. I would like to welcome everyone to today's seminar, Evaluating Clinical Performance Challenges and Some Best Practices. This webinar is sponsored by Springer, and our presenter is Dr. Marilyn H. Orman, who is Thelma M. Inglis Professor of Nursing at Duke University School of Nursing. Dr. Orman's scholarship focuses on nursing education with an emphasis on studies of the nursing literature. Dr. Orman is author or co-author of 23 books, several of which have won national awards, more than 190 articles in peer-reviewed journals, and a wide variety of other publications. She is a member of the American Academy of Nursing and National League of Nursing, and has received a number of prestigious awards, including the NLN Award for Excellence in Nursing Education Research. Among her books are 4 with Springer Publishing, the most recent of which is Clinical Teaching Strategies in Nursing, 6th edition, which was published this January. Though not a focus of this presentation, we will provide some title information at the end of the talk. We will compile questions and address them at the end of the seminar, but please ask your questions in the chat throughout the presentation, and then I'll read those questions to Dr. Orman, and she will provide a response. And with that, I'll turn it over to Dr. Orman.
Okay, thank you so much, and everybody. I'm just delighted that you've joined us today. And I'm going to give you some principles I hope that you can take with you to guide your clinical evaluation, whether it's with a pre-licensure group or NPs or preceptors, whatever that might be. So I really tried to gear this to some broad principles that it doesn't matter what level you're teaching. I think these will fit for you. And then when you look at really particular needs of a preceptor working with an NP. That I think you need to find in the literature, but I'm going to talk about the literature as well. So let's start out by thinking about clinical teaching. I think it's the most difficult area to teach in nursing. I've said this for decades. I think it's even worse now. Because if you think about clinical teaching, this is where we have so many challenges for schools of nursing. First of all, everybody knows there continue to be faculty shortages within a school of nursing, but shortages of adjunct. We know from many, many studies we don't have enough clinical educators, and the ones we have are often not well prepared for teaching. So we have a shortage, and then we really look to the adjunct or the clinical nurse educator pool, but so many of those educators are not well prepared for teaching. You can become a good clinical teacher if you were a good preceptor, but I don't think you have the skills without some education to really do valid and reliable evaluation of performance. So I've always thought, and I still believe, that a clinical educator who spent time as a preceptor can really transfer those skills to teaching. But it's the evaluation component, the focus today, that we really need to look at in schools and really think about how we can prepare educators to do a better job with evaluation. Today in clinical teaching, the practice environments have become increasingly complex. We know from studies, unfortunately, students go to clinical sites and there are extensive restrictions. Hansborough, we published an article last year, it was a national study, just an amazing number of restrictions, particularly with EMR across settings. But we know other skills students have, but they learn about it, but they get to the clinical area and they can't really practice it. Many schools are trying to, in addition to all of this, build in more primary care experiences, get students out to the community, but not just the community, really build some competencies for primary care. And then the last bullet I think is really, really important. There's not a huge pool of evidence for best practices in clinical teaching, and there's even less for clinical evaluation. So this is really important. We do have some studies on clinical teaching that will affect how you evaluate performance, but not a huge pool like we do on simulation, a growing number of flipped classroom, online learning, although students spend so much time in clinical practice. So we do have a need to build better evidence to guide clinical teaching and evaluation. And I think the other issue with clinical nursing education, many of us still use a traditional model where there's a faculty member or an educator, clinical educator, an adjunct from the school who works with a group of students on a set day. So most schools still use this traditional model. But unfortunately, if you don't have a skilled educator looking at the possible experiences in that setting when the students are there, we have to question if that experience is really helping the students meet the planned competencies. So one of the issues with a traditional model is it really is dependent on when students are in that setting. And I think that if you have a skilled educator, we can compensate for that because the educator can find exemplars in that patient care setting that will help a student meet some competencies that they know about ahead of time. We also know, as I mentioned, that we don't have a lot of evidence for the teaching and evaluation component. What we do know, however, from studies is that many studies have indicated that graduates of nursing programs are still not well prepared. They lack skills. We know that from studies. They lack clinical judgment. We know that from studies as well. They need much more experience in that residency. We know that as well. And we know the exact same thing for nurse practitioners, which is why so many settings have moved toward residency programs for practitioners. So what we're doing now in that traditional model, I think we really need to build a little bit better quality to focus on making sure students in the program are practice ready, that they're ready to have certain activities that they'll be competent in when they graduate. We have newer models of clinical education, and these have pretty good outcomes. I'm always surprised that these haven't really been integrated as much as I would have thought. Good studies on DEUs, dedicated education units. They shorten orientation time. They build learner confidence and skills. So we have that. We have a couple of studies on a clinical immersion model where students have their theory front-loaded, and then they have large blocks of time for clinical. We need more studies on that. And then we have other studies where the staff nurse is really, it's almost like a modified DEU, but the staff nurse becomes the educator as well. So beginning studies, good outcomes, but we need more of that. And then we have tons of research on simulation. But what I don't see in the literature is what is the link between those simulation experiences in your school and actual clinical practice as graduates? So we don't know how it's transferred from the School of Nursing into practice. Without that knowledge, we can't better design simulation experiences. Where should they be in the curriculum? How much? Should they be before clinical? Should they be after? How many times should we repeat performance to build that a better link to practice? What we do know is expert clinical teachers have knowledge about the content they're teaching. They're experts in clinical practice. They have good teaching skills. They know how to interact with students. They know how to deliver negative feedback to students, difficult conversations. They have good interpersonal skills and positive interactions. And the last one, we know you have to be enthusiastic, be a good role model. So this slide shows evidence that we know that I can tell you has been studied sufficiently. We also know, as the clinical educator is giving feedback as part of evaluation or instruction, we know feedback has to be specific. It's geared to fill gaps in learning, so we say it has to be informational. What you observe the student really isn't understanding or doing. My role as the educator is to give feedback that fills in that gap, that explains it, and we know it has to be prompt. That's important. That bullet's important because feedback is a critical component of performance evaluation. So a lot of times we think of evaluating performance as being the summative at the end, the midterm, the end of the rotation. But actually, feedback is what we should be doing as students go along, developing their competencies versus really emphasizing at the end. And we know, lastly, that students need preset deliberate practice. They can't learn it once. They can't be checked off once. They need to practice it deliberately. They have repetitive practice where there's some assessment, giving feedback, filling in the gaps, correcting poor performance, and we know that that makes a difference. So deliberate practice, we know, improves competencies. I think it's really important when you think about evaluation. We shouldn't be evaluating competencies that the students did once or twice in the skills lab and we checked off. That's not enough practice, and there's evidence to support that statement. And then lastly, we know from studies, the more practice a student has, the better performance. And that practice is correlated to expert performance. So we have good research on this. Whether or not the clinical educator knows this and can build that in teaching and evaluation is an additional question, which I don't have an answer for. And then one other component that we know a lot about before I really shift to evaluation, I just love these studies. We know that if studies of students in nursing programs have documented for years, clinical practice is the most stressful. And studies across a really pretty long period of time have documented students are fearful of making a mistake. They don't have confidence in their skills. They don't have confidence in their clinical judgment. We know they're stressed when they have to interact with providers, physician, PT, staff nurses, and the instructor, unfortunately. And they've reported that being observed and evaluated is another source of high stress. And so we know, as we're thinking about teaching students and evaluating performance, I think this slide is really important because it's suggesting that we need to keep this in mind when we make observations and we make judgments about performance. Students might be less stressed in a lab than they will be in clinical, and it will affect their performance. And I just wanted to summarize the kind of the research and the clinical evaluation. This was a great study published 2 years ago where the researchers looked at 88 studies on clinical evaluation and found very poor development of an evidence base. All the studies were basically single studies that you couldn't really add together and build evidence. So this is an area we need more research on. So thinking of that as our framework, let me shift now to clinical evaluation. And if you look at the theory of clinical evaluation, it really includes two components: observing performance, and you have to be good at that, and then taking those data and observation and thinking about what the judgment might be. Is that student progressing toward competencies? Have they met the competency? So it has two parts, and you need to be skilled in both parts to be an effective evaluator. I don't think clinical evaluation is objective. Sometimes people tell me they're working toward an objective process. I think it's subjective. And I think we're better off as educators to really have our standard to be fair, recognizing that our values and biases might influence what we see in our judgments, but we have to stick to the competencies. We need to judge all students by observing them, making a decision on if they're competent based on whatever those standards, or in our own language, competencies would be. So you need to know your own values and biases. Recently, I think it was just last spring, I published an editorial where I'm trying to rethink clinical evaluation, and I really like this model where we can think about clinical evaluation having two roles. One of our roles is evaluating performance for learning, where we're collecting information, we're making an observation, we're giving feedback, but the goal is to help the student perform the competencies at a higher level. And so I used to call this formative evaluation. Actually, I still do, but I think it's another way of thinking about it is really to think in evaluating clinical. One of my roles is to evaluate, but link it to learning, evaluate to help students learn. And then another way is to evaluate what they've learned, evaluation of learning. And this was the editorial in January issue, where we're evaluating at a set point in time because students at this point in time have to perform the competencies. So I really like this way of thinking about evaluation of clinical practice, where we have some evaluation that's really formative to help them learn, but at certain points in time, the preceptor has to document that this NP student has met these competencies for that course. And then the same for our pre-licensure students. So what do we evaluate? Deborah, ETI, I think she's probably on the Zoom, is on the Zoom now from Washington State, emailed me. She said she was going to come, and I've been thinking about this since we conversed by email about using these concepts for NPs. And I think this slide is really, really important, whether you're teaching ADN, LPN, accelerated baccalaureate, whatever it might be, all the way to NPs. You can't do clinical evaluation if you are not clear as the educator what the competencies are to be developed. So this is a slide, that I would recommend you keep in mind as you prepare educators or you do this yourself. No matter what model you think about for clinical evaluation, the framework is we're collecting data, we're making observations, we're making judgments based on those clinical competencies. If you subscribe to the essentials, we're moving into a new set of competencies. But if you don't use the essentials, it doesn't matter because it's the same framework. The clinical competencies are the knowledge, the skills, their attitudes that students have to develop in that clinical course, in that program level, as outcomes of your program and be able to demonstrate. So if you think about clinical competencies, these are the knowledge, skills, and values to develop, but also to be able to demonstrate. So our clinical evaluation needs to collect data to determine if those competencies have actually been demonstrated or if the student is progressing to meet those. This is my second slide, and I had this big word match because I think what we haven't done well enough in nursing that now we really should do moving forward is ask ourselves, when you're in the clinical field, no matter what you call it in your school, no matter what model, what are the competencies for that experience, that rotation, that practice, that week, however you look at it in your school? What are the knowledges? What are the skills? What are the performance competencies that students should be developing in that clinical course or have met at the end? And so I like to think of the word match because we're matching the evaluation directly to the competencies. And if you use the essentials, there's lots of competencies. You're not going to have one clinical evaluation method per competency. You're going to take broad competencies that link together and have a series of methods that you use to determine if students can perform that competency in your course. So we have lots of clinical evaluation methods that have been described over the years, and I don't have time in this webinar to go over those, but this is a good slide. We think a lot of times just about observation, but actually we're using simulation or SPs or written assignments in courses, your rating scale. Any of these can be matched to the competencies that you are evaluating in your course. So when you think about clinical evaluation, it doesn't have to be just observation and your check-off rating scale in clinical, because these other methods you might put in your plan for clinical evaluation as other ways to measure competencies. So this slide I think is really important because I think too often educators, when they think about clinical evaluation, they think observing and checking on the scale. But there's really a whole wealth of other methods that you can build in your clinical course as a way of determining if students have met the competencies. So what are some best practices? Observing students in the clinical setting, it's the predominant way we do it. It's the way probably our adjuncts and our clinical nurse educators will do it the most. Number one, focus on the competencies. Every educator collecting data, making an observation, coming up with a judgment, has to put the student's level of experience in a perspective. And so we know from a few studies that preceptors, nurse managers, and staff nurses was the other setting, oftentimes expect the student to have a much higher level of expertise than they do. So in courses that you're offering that are precepted, or that, and then the faculty member might rotate, or it might be completely a course that's preceptor-based, some instruction has to be given to those preceptors and other staff, because studies suggest the practice level, staff nurse, manager, et cetera, have too high an expectation of students' skills. And if the student's only done one or twice, they can't do the competency probably as they begin that clinical. Number two best practices is watch your first impressions of students. Studies suggest that sometimes when we observe a student in a performance situation, we're observing performance, we have a first impression. Oh my heavens, what's that student? How am I ever going to get through this course? A negative one or a positive one. But if you think about that as observations go on, you might change your impression. So the best practice is forget about first impressions. Don't come to any general ideas until you have made a series of observations. If you're using a traditional model and you're working with a student on a procedure or a skill or a patient assessment at 9 a.m., keep in mind it's a tiny window of time. And what you see at 9 a.m. might be completely different if you happen to be going into that room at 1 p.m. So keep in mind it's a window of time. And research suggests observations in clinical performance we need to make over time, so we have a pattern of performance. And then lastly, we know for studies is that sometimes faculty are really good at collecting data, they make notes for themselves, they have really good observation skills, but when it gets to making it pass, fail, or whatever your system is for your rating scale, they actually are either too negative or too positive. So the data are good, but the judgment may not be. And now I'm going to talk a couple of some best practices for your tool. Somebody many, many decades ago wrote a wonderful article in a nursing ed journal that said schools of nursing are always changing their rating tool. There's problems in clinical evaluation, so they figure it's the form. Well, it may not be the form. It may be the educator using the form or how it's used. So I really don't think we want to be revising our rating tools every single semester versus really preparing faculty to use the tool as intended. I'm going to talk about that in a minute. So what do we know about your rating scale, your rating tool, your clinical evaluation tool, your performance tool, whatever you call it in your school? Number one, schools of nursing use all types of tools. My own sense is pass-fail is the most significant, most frequent. The last study was done, we actually did this, I think like 2003 or 2005, so I don't know if it's still accurate, but my sense is people tend to use pass-fail predominantly or met the competency or not. Some schools do a letter system, some have a matrix, where you're ranking frequency, dependency on the educator, and quality of performance, more of a matrix. I would recommend that your form be competency-based, that what you see on the list of competencies, the list of objectives, be specific competencies. And now if you use the essentials, they should come from the essentials document and or your course. Make it competency-based. Make sure those competencies are measurable. Make sure everybody in your course using the form understands what you mean by those competencies. So it has to be reliable, where people read the form and they know what you're talking about across your many, many sections of a course or used by preceptors. And make sure you don't have too many competencies. I think with our short clinical courses, with our adjunct faculty, wide use of adjunct faculty, with particularly in a clinical model, we probably can't collect enough data for a form that has pages and pages of competencies. So I would like to say it's the last best practice for your rating tool. Look at the number of competencies. So they have to be measurable. They should relate to competencies either that you're pulling in from the essentials or whatever framework you're using or your course. They have to be measurable. Everybody has to understand them and implement them similarly, have to be reliable. And I don't think forms can be too long. If your form has 30 competencies and it's a 5-week course, it's probably impossible to evaluate a small group of students by that number of competencies. So I think today in schools of nursing, we're better off to really combine some of those competencies so we can say it's a realistic number for what the clinical practice experiences are for students. To make a tool reliable, improving the use of the tool, we know from the simulation literature, which I'm actually applying here to the clinical evaluation one, you have to have regular discussion of competencies. Every single person in your program, every preceptor you're using in your transition or capstone course, every preceptor you're using in your NP course has to understand those competencies. I don't think they can understand them when we send them and we say, make sure you read over the evaluation tool. I don't think that's effective anymore. I'm not sure it was years ago, but it's not now because not enough people are prepared to do clinical evaluation. So have regular discussion of those competencies to be rated. If you're only allotted an hour to orient a clinical nurse educator or a preceptor, I would use 40 minutes to go through the form because the form is so important and understanding of the competencies for people to use it reliably. I think once a year, look at your tool. Don't revise it, but look at the tool first. What's working, what's not working? Do you have to supplement with other evaluation methods because the tool really doesn't, it's not enough to collect enough data that you want to pull in maybe an OSCE or maybe a portfolio as other methods. But don't revise the tool every year. Run it a couple of years because sometimes the variables are student related, clinical educator related, and you find the next time you use the tool, it actually was more effective. And prepare your educators to rate performance using the tool. And so in other fields, people do rater error training, and I think this would work really well for clinical evaluation. And I actually have not read research on this, but this makes sense conceptually, talk about the tool, what each competency means. Have your new educators or your current educators say what each item on the tool would mean to them. Share what your intention was when you developed the tool and share with educators the kinds of errors that faculty make when rating performance. So what are some of those errors? Well, some errors are people have a halo effect. they do okay, student does okay in the first set of assessment competencies, you assume they'll do okay on the rest. Some faculty, you might know them, tend to be really lenient, always pushing students that they may only be at the middle of the road, but they're going to rate them higher. Other faculty, you might know them as well, tend to be more severe with their ratings. We know if an evaluation form is developed 1 year, and if you don't do some sort of discussion about that tool, studies suggest that we have what we call rater drift. That the next year, some of the faculty know what you're talking about for the competency, but as the years go on, we don't really remember what we were thinking about when we put that competency on the tool. So I think it's really important, and as you prepare educators with the tool, is have them maybe do a video. Everybody collects video recordings. You can get something on YouTube this day. Have people in your course take the tool and look at the video and rate the competencies, but then discuss them. What kind of observations did they make about this 2-minute scenario they saw on a YouTube? What would that be in terms of their judgment using your tool? And actually talk it through so that people are understanding what you mean by the competencies and what the standards are to pass, fail, or for each of your letter grades. And as you do this with educators, then some of the literature from simulation has indicated it is like an iterative process, that the faculty observe the video clips, they observe the performance, they rate it, they talk about it until your small group of faculty in your course come to some consistency. So we're doing this preparation for your tool as a way of bringing your course group together so they really understand what these competencies mean, validity, and they can use the tool consistently. So I hope I shared what I consider to be best practices for clinical evaluation. We began with what we know about clinical teaching to have the framework. And then I talked a little bit about some broad concepts of clinical evaluation that I think apply to any evaluation. And then we really moved into building an evaluation system based on competencies, matching your methods with competencies, and being sure you prepare faculty, educators from the clinical setting, preceptors to use the tool. And we have time for questions. I really did this so we have lots of time for questions at the end. So I'm going to stop sharing. And now we're ready for questions.
Okay, Marilyn, people are not being shy with the questions, so I'll prepare you for that. Also, a heads up, there were a lot of questions about access to the video after the presentation. Everybody who's registered for the webinar will receive an email, and we're going to post that to springerpub.com/videos in about a week. You'll get that link, you'll get an email. So, don't sweat it. You will get information about accessing this after the fact.
And Joe, you can also post the PowerPoint if people think that would be helpful.
They probably will. I appreciate that. Yeah, I think that's a good idea. Okay. So I'm just going to go down the line in the order. And we did get some questions, like I said. This is from Anonymous. Is effective transition to practice a bigger issue in the RN or APRN markets, or equally challenging in both?
I think it's probably equally challenging. I have not seen quite as much research on the APRN, but there's a lot of research on now that nurse practitioners are not prepared for beginning practice, but I can't tell you actually the breadth of the research. But what's really interesting is we're getting more articles now from the health system side, where the health systems have developed residency programs to transition the nurse practitioner. So people are realizing the agency has to put the cost in because people aren't coming into those practice positions well prepared. But I would say it's probably equal, but lots more research on the RN pre-licensure side.
Okay, thanks. From Joanne McDermott, what does Dr. Orman think about potential decrease in nursing education preparation related to AACN dismissing nursing education as a specialty?
Okay, so we don't have an hour, or you'd really see my hair was brown before it turned it white. I think schools have to look at what kind of model can they propose to continue to prepare nurse educators. So for example, you could offer a certificate in nursing education, which we have in our own program, or you can look at your master's in nursing education and ask yourselves as a faculty, how can you meet those AACN essentials with that program? So I'll just tell you what we're doing. It hasn't been approved yet, but I think it's going to be an effective way to do it. You can build in nurse practitioner courses in addition to your master's. It's a pretty long number of hours. We're transitioning our MSN to nursing ed to an MSN in nursing ed plus population health. Because with population health, there's not a certification. We have a little bit of room for kind of wiggle room, and people who do population health do a lot of teaching. So I think the certificate in nursing ed is a really easy model. And actually, if you email me, I can send you our certificate program, but it's also on the website, I think. We offer 9 credits. Our certificate is 9 credits. And we offer it for master's educators, DMP, PhD, or faculty, so that's one model. But we're also what I call tweaking our MSN in nursing ed program, because people need to prepare nurse educators. So you can see I'm getting worked up already.
Okay, let's go to maybe a more mellow question here from Kristen and Sorge. Apologies if I'm not pronouncing that correctly. What is a reasonable amount of clinical competencies that can be effectively assessed? Our clinical evaluation tool has 8 student learning outcomes, and within each SLO, approximately 5 to 6 areas that we evaluate. How can faculty truly evaluate 40 to 48 subcategories?
Yeah, I think it's really hard, Kristen, to do that, because you don't, especially in a traditional model, you don't have enough time to make observations of all those students. So I see 2 suggestions. One is you could keep those 40, which you have about 40, but you could say as a faculty, not all the data for determining if the competencies were met will come from an actual direct observation, that you might develop 2, 3 written assignments for your clinical course that are actually linked to some of those competencies. So you're actually collecting evaluation data, but from non-observation experiences. So that's one way. The objective structured clinical examinations, OSCEs, have really good reliability data. Schedule a couple of OSCEs in your course, take some of those clinical competencies and shift those. Say your plan for evaluating those competencies, it's not coming from the clinical section. It's coming from the OSCE or the assignment. And if your faculty don't want to do that, I would say take some of those sub-competencies and combine them.
Okay, this question is from Candace Smith. Does anyone have a formal instructor training program? What is included in the training? How much time is spent training, developing, and evaluating instructors?
So there's some schools do have formal training. One of the things, if you go to the nurse educator website and you type in the toolbar, I think if you type in something like clinical educator preparation, you'll probably get some articles, but some schools have that. Salisbury State has one that I think it's actually all online. Other schools have kind of preceptor preparation modules. So some schools have actually done that. I think you have to do it if you're bringing in a lot of new people.
Okay, next question is from Erica Hoyt. Would you repeat your thoughts about the gap in research related to simulation and clinical practice?
Yeah, so simulation is a really interesting area. I always use that my example of tons of nursing education research. But what we don't have studies on is the kinds of activities that students are doing in simulation, the kinds of competencies they're meeting through sim. How do they translate to the practice field? So just as one specific example, we do a lot of interprofessional education sims with our student. I want to know, does that sim make any difference when the students graduate and go into practice? How many of those sims would be needed? So we don't have that kind of literature. We don't have studies that are really bridging the simulation experience with practice. And we have a couple of studies where people have looked at, in a course, should simulation be first, then clinical? Should clinical be first, then sim? Does it even matter? We have Fowler did one study, and I can't think of it. There's another person as well. We need more of those studies to look at that.
Okay, next question is from Carolyn Ortiz. What is the current landscape from your perspective on paying the clinical preceptors who will be teaching and evaluating our students?
You know, some schools have to do it, particularly at the graduate level. I think it's really a problem for a school of nursing, even, you know, at the level at Duke where we have resources compared to some of the state schools. It's really a problem, but I know for a fact some schools do have to pay preceptors.
Yeah. Here's from Anonymous. As a community public health nurse, I find it very difficult to observe 20 students at community-based agencies. I also teach the didactic of 40 students, besides my other classes I teach. This area of nursing, unfortunately, is not taken seriously. Community public health teachers do not have a voice as hospital in simulation. Please help.
So I think, you know, so community health, a leadership course where students are scattered across maybe settings doing some leadership development, those kinds of courses where the faculty member is really not on site. I don't think observation and rating form is a good method. So I want to say that again. I just love this question. If you think about community health, even primary care spread across our rural health practices, the teacher isn't there. So I think as a faculty member of the course, think about what are other clinical evaluation methods could be used. So it might be for your course, you don't have observation and a rating form. Instead, you might use electronic portfolios where the students take a set of competencies for your course. They have to provide the evidence that they've met those competencies. Then you might have students do some patient teaching where they video record it, and then they do that patient teaching with their plan with the patient in your public health clinic. You evaluate the plan and the video. So I think for some courses, if the teacher can't be on site, observation and rating forms, it really just doesn't work because they're not designed for that. Think about other models. I really like electronic portfolios. So good literature-based, not research-based, but really good literature-based on using portfolios.
Okay, I think this may have been answered, I'm not sure in the presentation, but from Anonymous, can you provide an example of a competency-based tool that you find to be an effective one?
There's some in the literature, actually offhand, I can't. So some of the Houston tools are competency-based, but I just can't right now. Actually, in our clinical teaching book, I think we have some, but I can't remember where those schools were.
Okay. Here's another anonymous question.
Wait, I want to go back to that question. No matter what it is, say to yourself, is this competency that you list measurable? That's the key. Is it something that a student could demonstrate and then you actually measure achievement? That's the key for what you put on.
Okay. Another anonymous question. How will the AECN's new essentials core competencies not recognizing nursing education as a specialty affect preparation of needed quantity and quality in educating pre-licensure students? I think it's very similar to the another question we had.
Yeah. So I think I would think I had my hysteria for that one. So.
Okay. I'll try to avoid that question if it comes up again. James Rice, nursing staff cannot evaluate student performance and achievement of course outcomes. Faculty are required to evaluate performance multiple times throughout each clinical day. This requires one-on-one time and formative feedback, which takes time. Do you have any recommendations on nurse to student ratios in clinical?
Well, the best practice would be as small as you can get it in your negotiation with your director. It's been all over the literature. Some of the states restricted, the smaller number, the better, of course. I think that's the practice. thinking about maybe an alternate model. If you're in a school where you don't have the resources to have 1 to 8 and you have like 1 to 12 or something, think about maybe an alternate model, like the dedicated education units, just as an example, or those similar models where the student is really placed with a staff nurse and learns the practice of nursing as in that team with that staff nurse. There's good research for that. So it could be you could use a combination of models. Some of the students might be in a setting where they are assigned to a staff nurse who you prepare for their clinical teaching role, so you don't have as large a group. But actually, I don't think I've ever read any studies that say 1 to 8, 1 to 6. Most people would say it's a smaller number.
Right. Okay. This is from Elizabeth Deng. I don't always get preceptors to return fax, email, evaluation tools. 7 competencies equals 4 pages. They don't always return those evaluation tools back. Do you have any recommendations on the use of electronic evaluation system for rating tools?
So yeah, so ours, you could put it in Typhon. We use Typhon and our tools in Typhon. I don't think they do. I can probably say not everybody does it then, but so there might be other models. So I'm not here to promote Typhon. I just know that's what we use. And we actually, I had done that as a project once. We uploaded our tool there. So that is probably one thing you could use. I've always thought too, for preceptors, that sometimes the tool is what they just don't have time to do because they're taking our students in addition to their own caseload, that you could do a video conference with them where you could go over the competencies. It could be 15, 20 minutes where you go over your competencies and you really ask at real time, how would they rate that student? Or do almost like a 360 with you, the preceptor, and the student to do it for some feedback. And then you can fill out the form because you do need the form for accreditation later.
Okay. This is from Mary Ann Wynn. For the rating tool, should we be able to see growth through the semesters? Currently, our form is the same for all clinicals and rates 3 as the appropriate score for all levels of students.
I think you should, if you're using the same competencies, I would think, thinking about your program and competency development and gearing learning to the competencies and then evaluating them, I would say as you're going through the program, you probably will see higher levels of competency, better performance. But the one thing to keep in mind is if your courses are really clinical specialty based, even though you might have a concept-based curriculum or competency-based, but the students are with clinical patients of certain populations. I think the thing you want to keep in mind is students need some time to really think about that clinical population in relationship to their competencies. So if I have been wellness and then I was at some outpatient setting, then I did community health, then the next setting I'm in acute care, it's going to take me some time to really take those competencies and really apply them to this patient who's acutely ill, who has multiple problems, that sort of thing. So across the curriculum, I think you should see growth, but at the beginning of a course, the students may not be at a high level that you would expect toward middle at the end. Okay. I don't know if that was clear. I meant it to be, but.
I think that was great. Next question is from Annette Buse. Would you recommend CUSIN as a foundational source of clinical competency evaluation for ASN programs? Don't use BSN Essentials.
Yeah, so I think the CUSIN would work. I think there's a section on the CUSIN website that has evaluation tools. I think you have to tweak a tool. So if you find one that you like and it's based on CUSIN competencies, which you're building in your program anyhow, I wouldn't use a tool just as you found it, because you want to think about those competencies and your curriculum and your students and the length of time of that practicum. So I don't think tools that you can take them from school number 1 and just use them in school number 2. I think they have to be modified within the framework of your curriculum.
Yeah, I just want to mention this because I actually have, the next question is about a rating tool. So there's a lot of questions asking for specific rating tools. I think what I'm hearing is that you're recommending people evaluate all the tools and find the best one that works for them?
Yes, so there's tools on the CUSIN website. There's a couple of articles in Nurse Educator that we published with tools. There's actually tools in the evaluation and testing and clinical teaching book, all different kinds. At I think it's the New Jersey College of Nursing, they have a really nice website where they have tools that they use based on CUSIN, and they're free to the public. So that's another source. So I think I would tell you to look at different schools, get some ideas of the tools, think about what are the competencies for your program, for your courses, for your ASN graduates, but don't use the tool exactly as you see them. I really think they have to be modified to fit your program and students.
Okay, and I think that addresses a lot of questions that have been coming up. Okay, this next one is from Christine McGrain. Appropriate number of competencies. Is there a best practice recommendation related to the number of competencies for each clinical course? Is it the same as classroom learning objectives, which should be limited to about 5?
I have never seen that for clinical. I mean, somebody might have written it, but I don't think so, because I usually try to review the literature when we do book revisions. I can't remember seeing that. I think that, 10 I would probably assume 10 would work. Just as an example, if you have a couple on assessment, you have a couple on clinical judgment, you have one on skills, you have one on medications. So 10, I'm guessing, would be a good number for most courses. Some people might have longer courses with more skilled faculty that you might have more. So the key is for that answer is thinking about your curriculum, the kinds of experiences your students are getting in clinical, thinking about your whole program, what competencies should be on these beginning courses versus later courses, what's realistic as well. And so some of that information, we don't do a lot of saying to faculty, what worked well with your tool? What would you change? What things didn't work? What were issues you're having? We don't do that kind of discussion as much, but I would think, May's coming up, if that's the end of your academic year, an hour discussion with those kinds of really feedback from your educators might be really worthwhile in tweaking your form.
Okay, this is from Bonnie Harmer. We are seeing many more students with ADA accommodations due to anxiety, ADD, etc. They complete exams, testing alone in quiet rooms, and get 1.5 to 2 times longer for exams. That's in parentheses. However, the same student has no official accommodations for their clinical performance. Any thoughts on how to address this in clinical assignments and evaluation?
I mean, I think that's a really good comment. I actually don't have an answer, and I would tell you for this, your own disability office, I think I would ask them in your local setting, because I actually don't have an answer for that. And I don't think I've ever read anything about that. So I can't answer it, but I would say the information would come from your own disability office. So I can think of students in our own program who have accommodations. I don't think anybody has ever said anything about the clinical ones.
Right.
But I can't answer that. In the clinical teaching book, we have a section on working with students who need accommodations, but I don't think we even have anything in that as well. So I'm sorry, I can't answer that.
Okay. This next one is from Caitlin Jean-Mogan. It seems like it would be difficult to match course competencies to course evaluation if using the exact same tool for every clinical setting. Do you recommend that different courses tweak the tool or use their own to better match the competencies for that course?
I think that's a decision of faculty. I think you could do either way. Like somebody had a question earlier where they said they had the same tool that goes throughout the program. Typically for those tools that each course is using, the competencies are stated very broadly, that if you have an acute care course or your exemplars in clinical are from acute care, the assessment competencies is written broad enough that you could look at assessment of multiple comorbidities, assessment of a critically ill patient. And if they were in a community health setting, they could use that same assessment of a patient in a community and as a caregiver. So typically the forms that are used across courses, the competencies are written broad enough that you can implement them in each course. The other thing I've seen with those tools across courses is that each course might have a few sub-competencies that take the broad area like assessment, but they relate it to assessment of a child, assessment in a community, just a couple of areas that they've actually adapted it for faculty. Other schools have courses where there's broad areas of competency, but the tool is different for each course. So I see both models. I would say pick the model that works best for your program, and then say to yourself, are they reliable? Is it valid? Do I have too many? And how am I going to prepare educators? I think the key is we don't prepare people for using the form well enough. I would like to see us in nursing ed shift more toward even the preparation, because I worry about people not understanding the form and making really important decisions about students.
Okay. Next question is from PD Roland. What about asking each student, so it's basically an idea this person has. What about asking each student at the beginning of the clinical day what their number one priority is for learning and for their patient? And then relate that question to the evaluation form.
Absolutely. I think it's just a great idea. It's been in the literature. I haven't seen a lot about it. I think it's just a great idea because we say in nursing programs, we're helping students build their self-evaluation skills. We need to actually be doing it then. That's a great idea. What are your priorities? What would you do with the patient? And then the teacher can fill in the gaps and say, this is a priority. I agree with this, but let's also think about, so you can really easily build in some clinical judgment conversation as well.
Okay. Next question is from Ruxandra Simona Pervalescu Kodria. I really hope I pronounced that correctly. A question regarding the video recording of the students. What is Dr. Orman's experience advice about obtaining informed consent to do this? In clinical, sim, from the student or patients too?
Yeah, so for let's just start for the nurse practitioner level. If you're doing it in a distant site and you have a preceptor with the nurse practitioner, my understanding is you have to, and you're going to show the patient, you have to have patient's written permission. I would put it in writing on a form. If you're doing that type of evaluation. So that's the one thing. I have never seen any video recordings actually in the pre-licensure literature on the clinical setting. The videos that I have seen used for evaluation have been in Sim Lab and Skills Lab. Even in those settings, you need some form that students sign before you videotape them. And I know in our own school, they sign it when they come in the door. They sign a form that you will have experience in simulation skills lab. We may videotape that, and you agree to those videotapes being used for educational situations. I think there's one statement like on for your performance evaluation for other settings. So I don't know for clinical, anything for pre-licensure, but I do know from the nurse practitioner side, you can't video any patients without written permission. But build it in your sim lab and your skills lab, some general form that everybody signs so you don't have to keep doing it.
Okay. So we only have two.
That answered that.
So there's only 2 minutes left and there are a few more questions. We're not going to be able to get through all the questions by the end of the hour. Do you want to show that slide of the book and maybe, you can bring this to an end?
Whoops.
Marilyn?
Okay. So I have to get it open.
Oh, is it all closed?
But that's okay. Wait a minute. We should be doing that, of course, except that, there we go.
There we go. And Marilyn, is there anything you want to just mention about the new edition?
Yeah, so we try to, the book's a little bit shorter. We try to really adapt it to some of the current models of clinical teaching. I know some people have asked about preceptors. There's a new chapter on evaluating nurse practitioner students. It's written by somebody teaches in a distance education program for NPs. So we've added that in the book as well. I have a chapter on using writing assignments for clinical teaching where I've tried to build in really looking at clinical judgment in addition.
Okay, and I think if you could just go to the last slide so people have an email address if they want to contact marketing about anything. My name is Joe Merida and I have a lot to do with the nursing textbooks at Springer. My email address is jmarita@springerpub. I'm sorry, it's not on screen, but you can find it on our website if you've got book ideas, etc. I'd like to thank Dr. Orman for her time and everybody that joined us. And everybody have a good day and week. Please take care.
Okay, thank you. Bye, everybody.